Okay, so now we're in class 2. Class 2 is basically talking about birth plans, hospital procedures, cesarean birth. And how many of you have already written a birth plan? Do you know what a birth plan is? What is a birth plan?
More or less, once and not once.
Yeah, you're once, you're not, and it's kind of your preference of birth. So I'm going to play a little activity with you. So just leave everything at the table for a moment and go ahead and stand up. You're going to be standing in front of the table. And I'm going to ask you some really simple questions. Nothing difficult. Now, we're talking about writing a birth plan, so I'm going to show you how you kind of start writing the birth plan. Now, the first question I ask you is going to be, will be incorporated in the curriculum today, which is, I would like to know, first of all, what time you would like to wake up if you could sleep as long as you could. You're not pregnant, you're not going to work, it's a day off. How long would you stay in bed? Okay, so people that still would wake up at 4 a.m., you're over here, and then this would be people that get up at 5. That's even on vacation. 6, 7, 8. This is 9. This is 10. This is 11. Noon. Anyone over here is not conscious till the afternoon, like where we are right now, about 1:30. So go ahead and stand. What time would you sleep? How long would you sleep if you could sleep as late as you wanted to? Okay, see? All right. Okay, this is 5. Paulo?
6 or 7.
6. Okay, early. This is 8-ish, 9-ish? Okay. Now, if there was a prize to give out, it would go to JC and Apollo. Okay, why is that? Because they have very different biological clocks. And having a baby, it's going to be easier if your biological clocks are different. Just because of all the stuff you have to do and the feeding of the baby. So kind of realize somebody's going to do the night feeding, somebody's going to do the early morning feeding, and it kind of goes along with what your biological clock is. But I do want to kind of warn you that there's no bottles, if at all possible, the first 3 to 4 weeks if you're breastfeeding. So how's the dad, coach, going to feed the baby? Very good, Logan. You bring the baby to mom. Basically the milk's always at the right temperature. It's always sterile. You just plug baby on, burp, change diapers, put baby back to bed. So as long as you're doing the breastfeeding with your breast, it'll all work out. But just kind of remember, she cannot go for 3 to 4 weeks without getting any sleep. It's just not going to happen. So the next question is, what kind of food do you like to eat? Okay? So over here would be vegans, vegetarians, people that eat perfectly every day, know your grams and proteins perfectly. Over here would be people that like to eat out at nice restaurants. That's your favorite thing. Over here would be like cooking at home, really gourmet. Over here it's cooking at home but simple. And over here is fast food restaurants like Taco Bell, McDonald's. And this is predominantly eating from vending machines while walking. So where do you go? Decide that. And you can bunch up. Okay. Okay, now this is all easy food? Or
This is like easy cooking.
This is easy cooking. And this is gourmet cooking. Okay. And this is vegetarian. Okay. Now the reason this question is important because after the baby's born, the first 13 weeks are called the 4th trimester. Mom is not doing any cooking. So you need to think ahead, like how you're doing all the meals, so mom is eating well. Mom needs to be resting as much as possible. Mom rests when the baby rests, and there is not enough time for housekeeping or cooking. So just prepare ahead. That's why I asked you that question. Now, go ahead and sit down, and I'll give you the last question. But I'm not going to have you stand up to show how you would answer it. But I'm going to have the partner guess how mother would answer it. And then compare notes. Okay. Now, we're going to be talking about birth plans. To write a birth plan, you have to ask yourself, what kind of birth do you want? Do you want a very low-tech birth as natural as possible with the least amount of interventions? Or do you want a high-tech delivery, probably with pain medication given in early labor? Where are you in that decision? So I'm going to give you your choices, and then coaches listen, and then you're going to see if you are able to pinpoint where mother would be. Okay, if mom wanted an epidural before labor began, she doesn't want to feel a single contraction. She's right over here. If mom wanted an epidural in early labor, she wants to get to the hospital early so she can get an epidural early, she's right here. Mom plans to get an epidural, but not until active labor, or, and, you know, she's going to hold off as long as she can. She's right here. Over here, moms that plan to get pain medication, but in late labor, and they're not sure what. This would be, you don't care. It doesn't matter. This is not important to you. Pain medication, that's right here. If you're over here and you would prefer to have a natural birth, no pain medication for the baby's benefit, as long as the labor is manageable, you're right here. If you're over here, you would like a natural birth without, and it's important to you, not just for the baby's benefit, but you want to experience that, you'll be over here. If you're going to be disappointed if you have a cesarean or an epidural, you're here. If you are having a home birth, you're definitely not going to have any pain medication, you're here. If you are squat in the jungle, no pain medication even for a cesarean, you're over here. Now, partners, tell mom where you think she is.
We don't have to say that.
You don't have to stand up, just tell her. Where do you think she is? Just tell her.
Oh. I think she's on the.
You don't have to tell me, just tell her.
Oh, I would know. Thursday. Really? Epidural during labor.
Were you right?
Active, and she said try before.
Okay. So did everybody get it right?
To me, I think that she doesn't want to feel anything at all.
So did he guess it right?
Yes and no.
Yes and no. Now, see, that's where a birth plan is, because you have to identify where you are. Then you write a birth plan, because a mom that is planning an epidural as early as possible is not going to write a birth plan saying, I want to walk, no IV, no monitoring. That doesn't go along with that type of birth. Where a mom that's over here, she may have definite things like she wants to stay home in early labor. She wants to basically have intermittent monitoring during labor. She wants to be moving and active and changing positions and being in the shower, in the tub. She's going to put that on her birth plan, because that's going to help her get the birth that she would like over here with the least amount of interventions. So writing a birth plan, that's the first question you ask, just so you can kind of, like, how do we write a birth plan? Now, if you go to your books, now we don't have to use the book very often, but I think it is helpful when you're talking about birth plans to kind of look at some of the amazing handouts that we have in the book behind the PowerPoints. So if you go to the second class 2 and you go to the end of the PowerPoints, you're going to see planning the birth of your baby, the thought behind the choices. And then you're also going to see a birth plan worksheet that is just really simple. None of these are, forms at all. They're ideas for you to kind of start the process of writing a birth plan. Behind that is hospital procedures, interventions, pros and cons, to also look at that as well. So that is some of the tools that you can use in writing your own personalized birth plan as well. So looking at where mom is, it does think about what a problem it would be if mom, for instance, was on this side of the room and wanted a natural birth, but the coach was on this side of the room, this side of the issue, and thought it was the stupidest thing ever. How would that make it difficult for him to coach?
He's not going to be supporting her as much.
It's going to be difficult. It's like running a marathon and you're riding in the air-conditioned car and say, just get in, I'll drive you to the finish line. You're sweating. You don't, forget it. It's too long. You're not going to make it. How's that going to work? So that's another thing to kind of identify, is not only what her feelings are, but also what your feelings are. Now, my personal bias is you should support mom in her preference as long as it's safe for the baby and herself. So let's see what's not safe. Well, obviously, I gave you some really extreme things over here, but that's not really a safe position. To never ever feel a contraction is not really realistic. And to have a C-section without any pain medication, is not realistic. So to hopefully come up to a position that is safe for mom and baby, and then support it as best you can. And as a coach, you do coach a mom perhaps differently depending on what her preference is on pain medication. That, for instance, if a mom really wants a natural birth, and she at 4 centimeters, 5 centimeters said, oh, this is too much, I don't think I can do it. You're not going to say, well, just get the epidural. What are you going to, you're going to say, let's try getting you in the shower. I know this is a time that women often feel transitioning from early labor to active labor. You feel overwhelmed. Let's wait a little bit. Set a goal, like let's try 30 minutes and let's see how you feel. Often, setting a short time goal for moms that want an unmedicated delivery, that sometimes gives her the ability to kind of regroup, get used to the contractions, get used to the rhythm of her own distractions, her own rituals, her own relaxation, and then she's, oh, I'm fine. It was just the change from early to active is quite a big change. So setting a goal for herself, getting that extra support, maybe getting her in water, getting her in the shower where she feels much better than she did like lying in the bed. So you coach moms a little differently too, depending. So I think it's very important to know how they feel about this issue, whether you have a birth plan or not. You should know what is important to them so you can still advocate whether you have a birth plan or not. Here we can see, this is Penny Simkin, amazing author, childbirth educator, physical therapist, probably the most famous childbirth educator in the world, written so many books. Birth Partner is one of them that you may be familiar with. This is her PowerPoint. Very interesting. It looks like chutes and ladders, but it basically captures a lot of information. We saw a labor just now, which was an unmedicated delivery, and she went down kind of the yellow brick road. She had kind of a long early labor. In fact, it was so long they sent her home. Told her to drink water, hydrate, rest, sleep, come back later. When she came back, she did pretty well in active labor, dealing with relaxation, getting in the tub, back pressure, counter pressure. Did you notice what her mom said to her when she goes, it hurts? What did her mom say?
So she was proud of her?
Yeah, and she said, and I do know, but you're doing really well and I'm proud of you, yeah. She did acknowledge it, and then she did support her. Then we saw her going through transition where she was more agitated, and her mom still was very calm with her, like, helping her get through that. And then pushing, she looked like she was in the zone. She looked so relaxed and pushing. And she went down the yellow brick road. Every birth is different, but seeing birth films kind of help you understand the journey and help you understand the coaching. Now, Epidural Highway. We're going to see next film when we talk about, after I talk about hospital procedures, we'll talk about the Epidural Highway. Here you are on the yellow brick road. Basically, early labor will be very much the same because you're usually not going to get an epidural in early labor. Why?
More,
So we need to feel the contraction.
Right, and
it's more easy.
right, it's easier, it's more manageable. You can do normal things. You should be, and you'll be home. You'll be home in early labor. I don't know too many dads doing epidurals at home. No, can't do that. Has to be an anesthesiologist, of course. It's very high tech. So you're going to be home using your own comfort techniques. And it helps labor progress. Once the epidural is given, you're in bed. And changing positions becomes more difficult. And labor can slow down if epidurals are given sometimes too early. That's one possible side effect. So getting through early labor without an epidural has the advantage of helping the labor progress. So then you get on the epidural highway and labor is going to be very different because you probably won't feel your contractions. You'll be basically in the hospital. It'll be a high-tech delivery because you'll be managed by the hospital staff. So mom becomes more passive. The goal is always the same, healthy baby at the end. We're all getting to the same place, though we may go a different direction to get there. We're also going to talk about posterior labor. Now, posterior labor is when the baby is against your lower back. This would be a baby in a posterior position versus anterior position. Anterior, the back is forward. If baby's posterior, mom is going to feel all the contractions in her back. And the progress of labor is much slower. Usually these posterior babies eventually turn anterior, and then the labor progresses back. See, she's back on the yellow brick road once that baby turns anterior. If the baby stays persistently posterior, it's possible to deliver the baby in the posterior position, but you would look down and your baby would be looking up at you like this. And since that's a more difficult turn around the pubic bone in a posterior position, it may not be possible to deliver a larger baby posterior because you're just not going to have the room to make that turn in the posterior position. So some babies that are persistently posterior are delivered by cesarean section. And some babies can be delivered posterior, or most of them really do rotate eventually into the anterior position. And then you're back on the journey to the same place a normal, healthy newborn in your arms. So now we look at, there's so many different ways to deliver a baby, then we look like how and why would we write a birth plan? So there are advantages and disadvantages to birth plans. So anybody know any disadvantages for a birth plan? Like why people don't write them?
Because you really have no idea how your labor is going to progress or what's going to happen.
Right.
And if you get too fixated on a birth plan, sometimes if it doesn't go that way, you can panic and
Have stress.
Yeah,
Right.
it becomes a very stressful.
So you can't control your birth, and that is so true. And we're so used to this modern society. We want our food on time, we want to organize things, and you can't do that. Birth is you have to flow with your labor, and that's very true. So you could be disappointed when it doesn't follow the birth plan, right? And that could add more stress. What else? Any other reason, negative reasons why?
Could be time consuming if you have a lot of.
It takes a lot of time, and basically that may be the reason. You have to sit down together, you have to discuss it, you have to, and then take your birth plan, discuss it with your doctor. That's definitely another disadvantage. Anything else that's a disadvantage with the birth plan? What are the advantages with the birth plan?
What's
You
your-
can, oh, go ahead.
Once your medical provider as well as the nurses know what you would like to happen if
Right.
in a perfect world.
Okay, in a perfect world, and sometimes it is a perfect world, isn't it? Most labors are normal, healthy labors, right? Most of them progress normally. And if, like when I asked you the question, what kind of birth you want, the nurse doesn't know if you want an epidural or she wants a natural birth. And if you want a natural birth, you want her to know that. So she's going to help you with everything she's got a lot of tricks in her repertoire that she can use to help you with that. So let her know that. Don't keep it a secret. So letting the nursing staff know your feeling about pain medication does help a lot. Then, and is there any other advantage?
I think, oh, go ahead. Were you going to say something? Oh, I was just going to say it gives you the opportunity beforehand to think through various scenarios of if this complication arises,
Right.
here's how I'd like to respond. So you don't just have to have one set birth plan. You
Right.
can kind of have different options because you're going to be preoccupied and you might not be able to think through like, well, I didn't anticipate this happening. What do I do now?
And that's very true about, for instance, we always ask if you're going to write a birth plan for a cesarean birth. You're not anticipating one, but you should have a cesarean birth plan, because if you suddenly switch to a cesarean birth, there's not a lot of time to say, oh, by the way, honey, this is important for me, you know, so this is a dialogue that you go through ahead of time. Now, in a nutshell, what are the advantages? First of all, it makes it very easy to communicate. Make your birth plan easy to read and make it short and simple, but it makes it easy for you to communicate to your nursing staff, your physician, what are some of the preferences that you have. And you may have a physician deliver you that you have not met before. So it's a great way to communicate that. I went over this with my doctor, and this is what that I find important, and I discussed it with my doctor, that all is realistic. Because you want to make sure you have a realistic birth plan. For instance, if you put down you want to have a water birth, at this time at TMC that's not possible. Maybe in the future, but at this time it's not. So that wouldn't be realistic for this hospital. So you want a realistic birth plan. So go with your physician, easy communication with the staff. The second is it gives the partner a lot more clout to advocate for her, because she may have said, oh, I want a squatting bar, but then when it comes time to push, she may have forgotten that she wants a squatting bar, or you just can't even get the words out that you want that. So it makes that a lot easier to advocate for her. And it does take time, but some couples, they want to take the time. This time, I mean, you're having a baby together and you're taking this class together, and this takes a lot of time. And so some couples want to take the time to do a birth plan. So again, remain flexible and never feel disappointed if you had to change your birth plan. You have to flow with your labor. And I give the example of a trip even. You know, this is a real true example. I was planning a trip to Russia next week, and I suddenly found out that trip is not happening. The visas did not come through. So then I had to plan a trip to Paris instead. But I'm planning a trip, but then everything I planned was out the door. But then I said, well, what do I want to do now? I can do this or do that, but now I'm making another. But then when I get to Paris, I may have planned things that are not going to happen. You know, it's not realistic. But certainly, I'm going to have a plan. So I think the plan is not a bad idea, and that's where birth plans are. So do not be disappointed if you change your mind. I mean, I can't say don't be disappointed. Be realistic that you may change your mind, and you make the best decision for mom and baby. Now, as we write a birth plan, there's some things you really want to put down on the birth plan, and some things you just want to talk about. Like we saw a birth that she had a lot of people in the room. Do you want that many people in your room? No. So think about who do you want in the room. Sometimes that doesn't have to be on your birth plan, but it's something you communicate to your family, and you know what's going to make mom comfortable. Because your birth environment is very important. Mom needs to feel safe in her birth environment, because birth is a mind-body experience. So you may not want your mother-in-law in your room, because you may want your mother-in-law in the room. I went to my son's birth, but I wouldn't have wanted my mother-in-law at my labor. So it just depends on what makes mother the most comfortable. It's not like a wedding and you have to have equal amount of people from both sides at your birth. So think of the people that need to be there and why. And even during labor, you may change your mind and say, I don't need these many people. I need more privacy. So remember to tell people she may change her mind during labor. So be open to that. When you're writing a birth plan and making decisions during labor, whether you're having a birth plan or not, we're going to go over some hospital procedures. You want to always step up to the bar. There's different acronyms for this, but I like this one because it's the simplest. bar, step up to the bar. What are the benefits of the procedure when you're making a decision? Do I have alternatives? What are my alternatives? And what are the risks? And then make your best decision at the time for you and the baby. And then go on with the birth. Enjoy it, because don't go back and think, oh, well, you know, the birth, you have to make decisions with your care providers that are best for you and the baby at the time. We're going to look at the benefits, risks, and alternatives of each of the hospital procedures. Hospital procedures, enemas are not required, and it may not even be brought up. But if you go into labor and you're very constipated when labor began, you may ask about that in early labor. Is that an option? Most women have loose bowels, so enemas are really not necessary in most labors. But every birth is different, every individual is different. IVs. Now, IVs are going to be one of the options that is very encouraged in a hospital birth. An IV keeps you hydrated during labor. It also is an opportunity, if you test positive at 37 weeks for strep B, to actually give you the antibiotic through the IV. It also is an emergency lifeline if there's any change in plans and medication needs to be delivered very quickly. They don't want to fumble for a vein. So when you're in labor, they tend to, once you're admitted, an IV is usually placed in the upper arm, usually in your non-writing hand is best. So you can still bend your wrist and use your arms freely. And some moms that want the least amount of pain medication, like we're talking about the moms that are over here, that want a natural birth, they may not want an IV or may go for IV access, like a heparin lock. So they don't have the IV, but they have the ability to get an IV very quickly. These are all things to talk about with your doctor. If you do have an IV, don't let it slow you down. You need to move. You need to change positions. And position changes decrease pain and speed up labor. Now, if you have an epidural, an IV is necessary before the epidural can be given. So they have to make sure you have a liter of IV fluid so your blood pressure is not as affected. It tends to drop your blood pressure. And they have to check your blood to make sure you can clot blood before you can get an epidural. So that blood test and the IV access has to be done ahead. So you're looking at monitoring. Have any of you been monitored already with an external monitor? Was it a non-stress test or?
No, when we were living in DC, I was walking the dogs and they pulled me over. And I was 23 weeks at that point, and it pulled me over very hard. So we went to the hospital and they had to check.
And they did that to reassure you the baby is fine and doing well. Babies are well cushioned in that uterus and amniotic fluid. So I'm going to pass this around. This shows you the external monitor. And the external monitor gives you the reassurance of how the baby's doing and gives you the pattern of the contractions. It tells you the frequency of the contraction and also tells you how long they're lasting, the duration. So the upper belt is a monitor that's going to pick up the contracting of the fundus, and that's going to tell you the length of the contraction and the frequency. The lower belt is a Doppler that's picking up the baby's heartbeat, and then that is graphed for you. And you can see the pattern of how the baby reacts to each contraction. And normally a baby has variability of his heart rate. That's normal. So this information is given to you. Of course, it's in your room. The labor and delivery nurse that's in the room is also watching the labor pattern. And also, it's at the nurse's station. So the nurses can see how the baby reacts to each contraction. So that would be the advantages of the external monitor. Are there any disadvantages of the external monitor?
Yeah, you probably can't move very far.
Yeah, it slows you down in moving somewhat, right? Slows you down in moving. And sometimes women think they can't move because if they move, they lose basically, the sensor is off where it's not picking up the baby's heartbeat. I once had a dad where the baby moved away for the Doppler and then it showed no heartbeat. And then the dad panicked, not realizing that this is an external monitor and babies do move around. So, you know, that I could have saved him that moment of panic if I just told him babies move around, and of course they're going to move away from the monitor, and you'll see periods of time you might lose the tracing of the heart, and the nurse will come in and reposition it for you. We also have an option here that's really nice. We have telemetry now. We can monitor the baby and the contractions while mom's moving and changing positions. And this is excellent for moms that have to have continuous monitoring but want to move. So I'll pass this around again so you can turn this on the back and see the telemetry unit. And we have several units at TMC. So that is going to be a big plus. What's the, pretty much the disadvantages with the external monitoring is also, I have to mention, sometimes dads get hooked on the monitor. What do I mean by that? They just stand in front of the monitor watching everything like a TV set. And poor moms over here say, excuse me, back rub. I mean, come on, guys. Hey, I'm over here. The dad said, oh, this is a great contraction. Look at that. Excuse me. So remember, there's plenty of people watching the monitor. Your job as a coach is to really make sure she has her ice chips and her cool compress and changing her positioning. Now, occasionally, an internal monitor is used instead of an external. If they're not able to use an external monitor accurately, or they're watching a pattern that they're concerned about, and they feel that they could get a more accurate reading with internal monitoring, they may suggest to go to internal. And that would be with an electrode that would be a scalp electrode that would be placed on the baby's tissue right between the scalp and the skull. So that would go down it would be, here's the electrode that I'll pass around. This is a guide tube, so eventually this would be this is a scalp electrode. So it's not going to hurt the baby, it's just going to go in that first layer of skin, the scalp, to pick up the baby's heartbeat. It would cause a pinprick in the baby's scalp. This is going to be more accurate. This would monitor the heartbeat. And then they put a pressure sensitive catheter inside the uterus to pick up the contractions. So they can see how baby reacts to each contraction. But internal monitoring gives you intensity as well. So if they're concerned that maybe the contractions are not as intense as they should be, this gives them that information because the internal monitoring tells you intensity as well. So I'll pass this around. This is internal monitoring. And this would be you wouldn't necessarily write this down like, oh, I'd really like internal monitoring. No. That's, if they say we'd prefer to monitor internally, then you would go through the benefits. Do we have any alternatives? What are the risks? You know, what are my choices? And they would go through that with you. Now this is an amni hook. An amniotomy is when they artificially break your water. And you'll see this done quite a bit in the movie. You saw it in the movie we just did. They broke her water. Do you remember when they broke the water? The amniotic sac? Was it early in labor or late in labor?
She was at 9 centimeters, so
Yes.
that's pretty late.
Now, why do you think they waited so long to break the water?
Was it because her labor was taking so long? They had to send her home?
Well, they didn't break it when they weren't sure she was even in labor so much then. But when she came in, they didn't break it. Her labor was progressing very well when she came back. So when she went into active labor, it was progressing well. So why break the water? Why break the amniotic sac? Because the amniotic sac cushions the baby's head, cushions the contraction so that it's more comfortable for the mother. You know,
Because it was natural?
and she wanted an unmedicated delivery. So she wanted as many comfort techniques as possible. She wanted to get in and out of the bathtub. She wanted the least amount of interventions. So they probably broke it because there really wasn't any. What are the pros? We look at going back to step up to the bar. What's the benefits of breaking the amniotic sac? To speed up labor. She was doing very well. The risk or the disadvantage would be the head is more compressed and she would be more uncomfortable And she wanted to be as comfortable as possible. So when they broke the water late, she, like the midwife said, you'll probably start pushing right away, which in this case worked out that way, and that labor. So we're looking at Pitocin. Now, Pitocin. Pitocin is the artificial hormone for oxytocin. And it's used to either augment labor, like you're in labor and your labor slowed down, so they need to add Pitocin to pick up the contractions, or it's used to actually artificially start labor. Now, do you know anyone that's been induced where they start the labor artificially? Yes? Okay. Now, according to the American College of Obstetrics and Gynecology, ACOG, induction should be for a medical reason, for baby's health or mother's health. It should not be because you're tired of being pregnant, because everybody's tired of being pregnant. It's not because your doctor's going on vacation. It's not because your husband has a job scheduling problem. It should be because of a medical reason. And there are medical reasons why we need to induce labor. One would be mom has passed her due date significantly. Not a day after her due date, but after 41 weeks, 1 week after your due date, you think about, well, baby's probably, even with kind of a varying schedule, is probably ready to be born here. So we're going to need to think about when are we going to go into labor, or do we need to induce? So post dates. Another reason is babies failing to thrive in utero. Mother's health. If mother has very high blood pressure, she's spilling protein in the urine. There's reasons why it's better for mom and baby to induce. But that's the criteria. It's for mom's health or baby's health. And sometimes moms think, oh, can we just induce now? Because I'm just like tired of this. I'm day late. Let's just induce. And you're on call, aren't you? Think about this. This takes a low-risk pregnancy to a high-risk pregnancy using Pitocin. So what's the reason for that? If you're induced, and I've been induced twice with my labors, I make it a positive experience, but really look at, again, step up to the bar. What are the benefits of this induction? Do we have any alternatives? Can we, wait a little longer? Can we do a biophysical profile? What are the risks of not inducing? Go over that with your doctor. Now, if mom is induced, how would you expect the labor to be different? I don't have that on that, that chart that showed the pathways to labor. First, you would expect the contractions to be more intense. Once labor actually gets well established, the contractions, instead of having a bell-shaped curve of intensity, tend to peak more quickly and go up to the peak of the contraction and stay there longer. So they're more uncomfortable. For moms that want the least amount of interventions, that want a natural birth, this is going to be more difficult because they're in the hospital from the very beginning. They can't labor at home in early labor, because when you're inducing labor, you're going to induce in the hospital. So you're going to do early, active, and transitional labor in the hospital. You have to be continuously monitored if you're being induced. Because with Pitocin, it's the artificial hormone for oxytocin. It has to be regulated very carefully, because it can cause hypertonic contractions that come too close together. So to monitor it very carefully by starting at a very small level, gradually increase it, continuously monitor it, and may even turn it off. They monitor it so carefully that they're adjusting it to use the lowest dose possible. Sometimes, we feel that if we induce babies that are a little bit, we think they're 40 weeks, but they're really 38 weeks, that may increase the chance of jaundice. So Pitocin is also associated sometimes with increased jaundice, because jaundice is caused from immature livers, and babies are not ready to basically handle the breakdown of red blood cells. So Pitocin can be used to augment your labor or actually start your labor. and it will require continuous monitoring. So, yes, go
Can
ahead.
you turn it down? Because I've had friends
Yeah.
that have their labor isn't progressing as fast as the hospital would like it, and they opt to give them this. You can turn that down, right? You can say,
Right, you can
"Do
always
not."
regulate it.
Okay.
And you can also say no. Yeah, you mean turn it, not just lower
Oh
it, but
yeah,
just.
no. I'm saying like I
Right.
understand my labor isn't progressing as quickly as.
And you could ask, what are the alternatives? What can I try? Now let's say
Right.
what can we do for Pitocin? Let's say they want to use Pitocin to augment, but you don't want to augment with Pitocin. What other things could you do?
Get up and walk around. different
Walking,
positions.
Squat.
changing
Yeah.
positions,
Lunge.
lunge, kissing. I was going to kissing a little kid. I was thinking kissing. It's even more fun than lunging. But kissing, cuddling, nipple stimulation. Now, actually, nipple stimulation is so incredibly good for producing oxytocin that you have to have supervision. I'm sorry. Supervision in the fact that they have to know that you're going to try nipple stimulation because they want to monitor it, because it can start contractions that are coming too close. Now, just like Pitocin can cause contractions, if they come too close, that can stress the baby, because the baby doesn't have enough time to recover between the contractions. So that's why if you're inducing naturally, it still may require some monitoring. Make sure that it's not overstimulation as well. So sometimes it's just turn off the lights, let's relax and get all these other people out of the room. Sometimes moms are just emotionally stressed as well, and that can slow down their labor. So step up to the bar. Like, what are my alternatives? And make decisions that are best for you and the baby as you go through labor. Now, the next thing is episiotomy. Now, episiotomies are a surgical incision in the perineum. Now, the perineum is the area between the rectum and the birth canal, the vagina. So this is the perineum right here. On this poster, you can see an episiotomy, how episiotomy would be made. An episiotomy is an incision that's usually made straight down toward the rectum, or it can be made out to the side, called a mediolateral. Episiotomies were originally done to speed up labor and to control the incision to make sure it's straight. So they would do the incision as the baby's head started to crown. Now, your mothers maybe have had an episiotomy when you were born, because episiotomies used to be very common and routine. And this is exciting to me because I've been around childbirth education so long that I've seen that revolution of almost everyone requiring an episiotomy. It's like, here's the baby, let's do it. It was not even a discussion. It was like, we need to do it, because it's always better to repair a straight incision than a tear. And then women, like in my childbirth classes, were saying, and everyone's childbirth class around the world was saying, excuse me, is there any research on this? Because I'd like to see it. And they actually researched it for 20 years. And the research supports that the best outcome is basically delivering the baby with an intact perineum and not doing an episiotomy unless needed, and avoiding a tear if at all possible. That's the best outcome. When you do an episiotomy, you basically create a path of least resistance. So that can extend along that line, and that can make more a third degree or more difficult episiotomy to heal. Most of them do heal very well. They're like small. As soon as the baby is delivered, they give you a local anesthesia and they repair it with absorbable sutures. But better yet, let's not have an episiotomy. Let's deliver the baby with an intact perineum, like you can see in this picture. In this picture, the care provider is doing a perineal massage. They also use a lubricant. They're probably telling the mom, right now, stop pushing and just pant and blow. and they're stretching the perineum over the baby's head as the mom is panting. And this is the crowning. Now this is when you feel that perineum is very stretched. It's very tight right now. And you'll hear women in the movie say, that's the burning part. That's what, that sensation of stretching. And then voila, the baby is born. And the perineum is intact. Now, sometimes with a perineal massage, if you're not doing an episiotomy, you may get a tear. Usually the tear is smaller than an episiotomy because it's not straight and it stops. But there is no guarantee in that. But that's what usually that's what happens. But sometimes a tear also needs to be repaired. So they give you a local anesthesia and the same thing, absorbable sutures, and as soon as the baby is born, the perineum is also repaired at the same time. So we have the delivery of our baby. So if you talk to your doctor about episiotomies, they can be a benefit. Going back to the benefits, alternatives, and risk, if the baby's in fetal distress, an episiotomy will speed up the delivery. And so there are times when episiotomies really are very helpful. And in retrospect, they usually are small and easy to repair. But with all the research coming in, your real goal is let's try to deliver with an intact perineum. So, have you talked to your doctors about episiotomies? What have you?
I just basically the same thing that you've said, that the research all supports. It's better to naturally tear. It's going to heal faster. The likelihood is that you might not even tear at all.
Right, and it's
And I understand it's a very progressive hospital, and that seems to be the ideology behind it.
Right.
Is that no, we don't do those unless it's absolutely necessary.
Right. So it's good. I got to live through this revolution, so that's good. And now let's go ahead and think of the little things. We've talked about all of the hospital procedure. I've talked about IVs and monitoring and amniotomies and Pitocin and induction or augmentation and episiotomy. Is there any, those are sometimes things that people put on their birth plan if they have a strong feeling one way or the other about it. Other things they put on their birth plan is things that they want to cut the cord. Like JC, if you're going to cut the cord, you want to put that on your birth plan. Say, I want to get in this position and I want to do that. If you're going to plan, you'd like to donate the cord blood, or if you would like to bank it independently for yourself, that would be on the birth plan. At this hospital, if you did not want the skin to skin, you would put that on, you know, because they're going to encourage skin to skin, the golden hour. That's going to be, so if for there was something else that you wanted to do instead, then you would put that down to let them know what's important to you. The first hour after delivery is pretty much the least amount of interventions. You don't need to do any unnecessary interventions like weighing the baby and putting erythromycin in their eyes. You can just let that baby snuggle. And then the second hour, you can start going through those typical newborn interventions, but bundle them together so they're less stressful for the baby, which is such a nice thing too. So that also people had to, you know, say, I really don't, I want to hold the baby, I don't want you to weigh the baby, you know, see now that's what you get, you know, so that's another thing is the changes. And you know, I will say, I think a lot of these changes came from what? I think they came from birth plans. People coming in and saying, I want the baby on my chest, I want skin to skin, I want, you know, and see over time, people looked at it, did the research, and couples made a positive difference in changing the family-centered birth experience. So looking at things that you want to put this on your birth plan, if there's anything you plan to use, you want to really let them know, like I want to be in the tub a lot. You know, I have a lot of imagery. I want soft lighting in the room and my twinkling lights. If there's things that you know that you're going to try to use in labor for comfort techniques, you can put that on your request list as well so they know. Now let's talk about epidurals. That would be on your request list. If you plan to have pharmacological pain medication, you have two choices, either an epidural or an IV narcotic. And that's pretty much your choices. Each one of them have advantages and disadvantages. So it really depends on you and your labor and what's going on. So let's talk about epidurals first, because epidurals are more popular than IV narcotics. And one reason why they're probably used more for moms in labor is they give moms more pain relief. Now, if you decide that you would like an epidural, that would have to be administered by the anesthesiologist, not your obstetrician, not the nurse. So the anesthesiologist would come into the room and talk to you about it. You would sign a consent form, and then the procedure would start. If the anesthesiologist is delayed a little bit, like let's say they're in surgery or it will be a few minutes till they get there, you might think of what you'd like to do before they get here, like go to the bathroom. Once you have an epidural, you can't urinate on your own, you can't get out of bed, you can't take a shower, you might want to take a shower, so use that time productively. Most of the time they're there very quickly, so you don't have an opportunity to do that. But if that did happen, I would say think of what you'd like to do. Once the anesthesiologist comes in, you'll get in a rainbow back position. So it'll be easier and more to administer the medication. Most times in this hospital, you are sitting up on the edge of the bed. In some hospitals, you lie on your side, like you can see in that poster up there. Mother kind of makes a rainbow back position. The anesthesiologist then cleanses the back and numbs the area where the epidural needle is going to be inserted, which is the lumbar region of your back. So if you take your hips and you draw a cross, that is approximately the lumbar region of the back. That is approximate area where the epidural is going to be administered. So once the area is cleansed, we have sterile draping. We've given the mom a local anesthetic. Usually that's the part that will sting a little bit, giving the local. The anesthesiologist will guide the epidural needle about 2 inches into mom's back, into the epidural space. Now the epidural space is really not a space, but it's a membrane over the duro, the protective covering of your spinal fluid. So when they're guiding the needle into the epidural space, they're positioning that by feel as they go through the different layers of tissue, and they feel this release of pressure, they're in the epidural space. Then they'll test to make sure they're in the correct position for the epidural needle, that it is in the epidural space. And then once they've determined that, they're going to guide a catheter through the epidural needle into the epidural space. Then the epidural needle is removed completely. So the epidural needle is really there to position the catheter in the epidural space. And once it's determined it's in the correct placement, the needle is removed. Then it's basically secured to your back, taped to your back, your shoulders, everything's in position. Then they'll give you the bolus dose. And then they'll wait, take your blood pressure, all your vital signs, and then they can put you, once they're determined that everything is perfect, then you can go ahead and go on a continuous infusion of the medication. Medication is a mixture of bupivacaine and fentanyl. Each hospital is a little bit different on the ratio, but the idea is that mom is getting excellent pain relief, but still having some control and movement of her lower extremities. In the olden days that was 30 years ago, when epidurals were given when I was teaching, moms would be given just bupivacaine, and they would be so numb that they really had no control of the lower extremity, and they felt nothing when it was time to push. They would not even feel pressure. So giving the combination of fentanyl with the bupivacaine gives mom the pain relief, but more control, more movement. Now at this hospital, we have patient-controlled analgesia. So once the infusion is in place, mom can increase the dose slightly to give her better coverage. If she's feeling that it's not enough pain medication, she can increase the dose slightly. It locks you out at a certain point. Yeah.
Hey, that seems a little dangerous.
Yeah, it locks you
Sitting
out.
there, like pressing that button, like more.
Right. What is the lockout? You do? 4. 4 in an hour. Now, I want to mention something that moms have told me about, is that when they're sleeping, grandma is pressing the button. So even though so that should never happen.
Terrible.
That is terrible, isn't it?
It's terrible.
And so what happened is when they got to pushing, they felt nothing because grandma had been pushing the button. Oh, they want to make sure she's comfortable. Now she's locked out at 4, but that may be way too medication for her. The idea with a patient-controlled analgesia is that everyone is affected a little differently and you can control it. So you go in a low dose, and if you need more, you can increase it up to a certain safe level. So that is basic placement of epidural. Now, at this hospital, only one person's allowed in the room when an epidural is given, and that person has to sit down. They don't let them hold the mom like they used to do in the old days. So the administration, now, Brenda, you want to add some more on the administration of the epidural?
The IV and everything.
Right, because the IV has to be given ahead. You have to make sure the mom can clot blood. All these things are done before, pre-test before. Now, what are the requirements for an epidural? Well, you've got the anesthesiologist, you have the IV for the rest of the labor. You're going to have a catheter used to empty your bladder, either intermittently, or some moms can still empty their bladder with an epidural, but more likely you're going to need help because you're numb from the waist down. So you won't feel the contractions, but you won't feel the urinate, or you won't be able to control the bowel and the bladder because you're numb from this part down. It's a high-tech procedure, continuous monitoring of mom's blood pressure, her heart rate. The baby will be continuously monitored through the external monitor or sometimes internal. And what are the side effects? Now the side effects, the lowering the mom's blood pressure is significant because that can cause fetal distress if mom's blood pressure drops significantly. So they have a vascular pressure dug to kind of be ready and waiting if needed. So you don't want that to happen. Soreness. Well, probably some women do complain of soreness. Spinal headache. Spinal headache is when the epidural needle punctures the duro and you're losing spinal fluid. That will cause a headache after delivery that will last for several days till that spinal fluid builds up. So what they usually will do so the spinal fluid builds up more quickly is patch it with a little bit of your own blood, a blood patch. That's about 0.5 to 1%. It's a very low chance, but if if you decide to have an epidural, that will be what you're recognizing that when you sign your signature on that. You recognize there is a chance of a spinal headache with this type of medication. Sometimes women say one side's really numb and they can't move anything, and the other side, they're still feeling the contractions. So they can try repositioning your body so that the medication is more equally distributed. Sometimes they even go in and they replace the catheter, so it is distributing the medication more equally. But first, often positioning the mother will solve that problem. Does it increase the chance of other interventions? Yes. Pitocin, monitoring, sometimes moms, pass this around, lose the ability to push, or they're so numb they can't push, and sometimes that may increase the chance of needing assistance, like a vacuum vacuum extractor. Now, vacuum extractor is used just if the baby is right there on the perineum to help provide suction and the traction so the baby can guide around that pubic bone. So it's not used very often, but it is, in some research, thought that perhaps interventions such as this may increase if the mom is not able to push in different positions or feel the urge to push. So a vacuum extractor will cause a hematoma on the baby's scalp that will take several weeks for it to completely go away. That's like a little bruise is a hematoma on the baby's scalp from where the suction cap has been attached. So on your birth plan, I know no one writes down, please deliver with a vacuum extractor. Nobody wants a vacuum extractor. In fact, you want to do everything you can so you push this baby out. And some things that are going to help you with being able to avoid a vacuum extractor is not getting too tired when you're pushing effectively, pushing low down to your perineum. Don't push in your face. The baby does not come out the face. So pushing like that is not going to help. Got to push low down in front, not just the upper body. All these things will help avoid needing that intervention. And it's used rarely. Forceps are even used. I don't know of one of my couples that have had a forceps delivery in the last 10 years. Do you know of any of your couples? Yes. But it's very rare. If they would use forceps, they're going to be better to actually guide. You can actually rotate the baby with the forceps, whereas the vacuum extractor is used just on the perineum. So if you're using forceps, you put in one blade at a time and the other blade, then they lock together, and then as the mother is pushing, you apply traction to deliver the baby. But the forceps can help a little bit more with the rotation. Forceps, though, can cause some bruising inside the vagina, whereas the vacuum extractor doesn't do that. You know, that's the advantage over why the vacuum is used more often than the forceps. What are the other side effects and benefits? We're looking at why is it so popular? Epidurals. It gives an amazing amount of pain relief, and it can be used throughout the whole labor. Mom is wide awake. Those are reasons why the benefits and why it's so popular. Now, how will it be different? Going back to the slides where it shows, like you can take Penny Simpkins slides. The woman is quite passive. Now, some women like that feeling of being passive, and other women, they want to be more actively involved. So that can be like a disadvantage because they say, I want to feel the contractions, I want to move, I want to change position. So that can be frustrating to a woman that wants to be actively involved. Other women, that works perfectly. Another complaint with the epidural is, where is everybody? Because then everybody kind of goes, oh, okay, whew, she got the epidural, let's all go to the cafeteria. And you don't want to do that. You never know when things happen. I had, this is a true story.
I have one, too.
What?
I have one, too.
Okay, you may tell it.
No, you tell yours.
Okay. It's a second time mom, and I was going to be her doula. And she got an epidural fairly early, like 3 or 4 centimeters. So I just said, I'm just going to take a quick run down and get something. I'll be back in 45 minutes. So I left. And when I came back, maybe I was 60 minutes, I don't know. But I met her husband going in the entrance of the hospital. And I said, well, what are you doing? And I said, I had to go home and feed the dogs. So then we walk in the room and she's holding the baby. So she was not very happy with me. But she was really not very happy with her husband. Her husband is really the one that got it. But it just shows you some labor. It was her second baby. It went really fast suddenly and no one was there. Everybody had left to go do something else. So you need to remember, mom still needs that attention. Mom still needs that focus. Some moms don't like the side effects. You may feel cold. You may, sometimes it's you shake, you know, and you need that comfort and you need that support. I had a mom that, you know, I still did relaxation and visualizations with her. She was a mom that on her first baby had a epidural late in labor and then had a cesarean. And she told me, I do not want a cesarean. I really want a VBAC, a vaginal birth after cesarean this time. Please be my doula. So I said, okay. And she did super well during labor, but it came a point about the same time at 9 centimeters where an epidural was her decision again, and then she basically started crying because she says, now it's happening all over again. I'm going to have another cesarean. I said, you know, you've done such a good job. You worked hard all day. What you need to do is just, you know, relax, and I'll massage you. And I read her visualizations, and that helped. You know, I was with her the whole time to make sure that she got that support. And that's what women need with an epidural. They do need that support. But the end of the story is she did dilate all the way to 10 and had her VBAC, and she was really, really happy. But sometimes coaches think like, what do I do? She doesn't need me as a massager anymore. What do I do? She still needs your support and your presence. And labor is unpredictable, so you need to be there to make her feel confident. When it comes time to push, they often delay pushing till the baby is on the perineum. And that is because it's been more effective, and because moms, when they told them to start pushing, when they first got to 10 centimeters, sometimes would tire themselves out. So they let the uterus push the baby down. And they kind of wait till that mom feels pressure, or there's some signs with the fetal heart rate that the baby is in the birth canal. Then they check mom, and then if it's time to push, they have the mom push. But they often delay pushing a little bit. That's become very common in most hospitals. When it's time to push, mom is limited to what pushing position she can use. You can use side lie pushing, semi-sitting. You can still use a squatting bar and kind of like use it as leverage, like that you see in that picture. She's holding it around the squatting bar to pull up and pull against. But you're not going to be squatting. You're not going to do gravity positions. You're not going to do hands and knees positions, probably. Because I can never say never, because I've coached moms that have had epidural and been able to do kneeling squats. But it's you pretty much, when you say you're going to have an epidural, understand that the likelihood of that happening is small. You're going to probably deliver in one of those positions that doesn't require you to hold your weight. So semi-sitting, lying on your side are all common positions. Now, any other questions or comments about the epidural anesthesia?
Is an episiotomy more likely with epidural, or?
No, I don't believe it is. I haven't seen any research that shows that it's more likely with an epidural. And Brenda, if you have anything, contradict me at any time. Not seen it.
I mean, I guess I'm wondering if you're undecided, like at what point is there obviously a point where you can no longer have one because labor is progressing too quickly, and then on the flip side, is there a point at which you should not be getting it so early because it could stall labor, and then you end up having a cesarean?
Very good question.
Like it's a very small window.
It's a fairly large window, actually. It's a large window. Now, in research has shown that there is an advantage for mom to get to 4 centimeters to minimize failure to progress. So getting into active labor it does help a lot because you've been walking and moving and changing positions. The epidural can be given as much more flexibility. It can be given in transition. The question is is it going to give you pain relief before you get to pushing? Because sometimes in pushing, moms don't need an epidural. Some moms would like an epidural in pushing, but some moms feel like they get a lot of rest time, they get a strong urge to push, and they feel in control, and they want to use the power of the contractions. They want to feel it. So that's something you individually have to answer. At 9 centimeters, I've coached moms that have had epidurals at 9 centimeters, and it's worked very well. I've had moms at 9 centimeters where they're going to deliver in 20 minutes. So what have you found? It just depends what's going on at that period of time.
Right, and here at Teensy, you can have an epidural at any time you ask for it.
So you don't have to worry about this window. I mean, you can have it in early labor. I just mentioned that, you know.
You're right, and the best policy is to wait till you have an active labor pattern well established. Once your labor pattern is established, an epidural could be a good choice.
And I mean, does it kick in fairly immediately?
In about
You said-
15 minutes, yeah.
Okay.
So about 15 minutes you'll be numb from the waist down. And then after delivery, it'll take several hours for it to wear off, maybe 2 hours. You know, after you leave labor and delivery, you'll get assistance in walking, and it varies on the length of time that it wears off. But usually that's within a few hours. You'll be able to get up and ambulate.
Times Grandma pushed the button.
Yes, Grandma. We can blame everything on Grandma today. Grandmas can be wonderful.
For pushing for more, is there a point that you can, say, okay, I think I'm good, maybe just be administered a minimum or not even at all, and then it'll just kind of go and then just wear off with time, or is it a constant?
Once it's on, it's at a constant level
Okay.
until
Until it's taken
till it's removed. And then you would get, if you wanted it removed before labor, you could get it removed. But it's not there. It's going to be on that continuous infusion dose, and then I'm sure if they can regulate it if there was some reason to regulate it, But
It comes through a pump that's on the wall, and it's got the bag of medicines in the pump, and the pump continuously infuses the medication. Out of the pump comes that cord that has a button.
and you'll see that when we go on the tour. You'll get to see that infusion pump as we go through the tour. And then, so what is your other options for pharmacological pain relief? The other one is narcotics. Now, narcotics have advantages and disadvantages over the epidural. They tend to be given, they can be given intramuscular or IV. IV is going to be an easier path and faster to administrate. They're going to take, compared to the epidural, they're easier to administrate than an epidural anesthesia or analgesia, epidural analgesia. It's going to take effect very quickly, faster than an epidural in just minutes. It'll take the edge off the contraction. It affects moms usually by being more sleepy. Sometimes they get nauseous with the narcotic. It doesn't take away the pain, but it takes your perception of pain is different. It will allow you to move and change positions. You are not numb from the waist down, so you don't need the catheter. You can empty your bladder yourself. Sometimes women that do not want an epidural, they want to feel the contractions. They want to go through labor. They want the least amount of medication. They may have tried a narcotic in active labor, planning to not have any medication in transition or pushing, and just use it for a small window of time. It's going to give you some pain relief for about 2 hours, and you're going to not be able to get narcotics in transition. So after 6 centimeters, it's rarely used, maybe 7, but never in transition because you're too close to delivery. And at that point, if a narcotic was given to a mom in transition, it could affect the baby. You could have a sleepy baby. You could have a baby that's not breathing as well, making that transition from water world to planet Earth as well. So they do have a narcotic antagonist to give the baby if there was a sudden delivery that was not anticipated, like mom got an epidural, mom got a narcotic at about 5 centimeters and then delivered an hour later, you could have a sleepy baby. So they do have narcotic antagonist to reverse the effect of the narcotic. But you don't give a narcotic if you think you're going to make, the result is going to be a sleepy, depressed baby. So you're going to tell the mom, sorry, too late, but you can still get an epidural later. So you're going to use analgesics primarily in active labor. Now, if you have a narcotic, could you still have an epidural? Yes, you could. So let's say a mom really wanted the least amount of interventions and maybe she had a narcotic in active labor and it wore off and she's still not close to delivery. She could still have an epidural later. So that's still a possibility. So now we covered a lot of medical hospital procedures. Nobody's smiling anymore, but kind of smiling a little bit. So any questions about anything? And we covered birth plans. We're going to see a film on a mom that had an epidural. And that will kind of highlight some of the things we've talked about. How one intervention can lead to another intervention, which is one thing that epidurals we have to be realistic about. It's more high tech. So we can go ahead and see that now. It should be ready to go. We're going to talk next about posterior labor. And just to review, most babies are anterior. Their back is forward. And that's the easiest way for them to maneuver through the passageway called the pelvis. And most babies are going to enter the pelvis and side to side, because entering the pelvis side to side, that's the largest entry, is side to side. Then they meet resistance from the cervix. That causes them to flex their chin on their chest, which is important so they can be as small as possible. And then as you continue to dilate, the baby is internally rotating. So the baby is internally rotating because the largest diameter now is from front to back. So as you're dilating to 10, that baby is making that rotation. So by the time you get to 10 centimeters, the baby's right against your back, right against that tailbone. That's why moms feel a lot of rectal pressure when it comes time to push. Then you're going to push the baby down, and then the baby kind of rotates back a little bit after the contraction's over. Then you get another good pushing contraction. You push the baby down. This time you're making more progress. And then gradually another good contraction comes, and voila, baby is made that right degree turn around the pubic bone. And now you're going to deliver the baby. So the baby extends up, and then they deliver, suction the baby's nose and mouth. The baby rotates. You have the anterior shoulder delivered, then the posterior shoulder, and then the baby slips out. Now, what happens if the baby's posterior? Posterior means the baby's back is against your back. That means the baby is going through the same cardinal movements, the little twists and turns in the pelvis, but you've got this, you're feeling all the contractions in the back. That's where it's going to, you may not even feel the contractions in front. So this can be a slow delivery unless you get the baby to rotate. So one thing that's going to happen that's going to help is get out of bed. Dance. Dancing in labor is actually a good thing. Dance. Move those hips. Let that baby kind of move around. Another alternative would be like leaning forward, getting in your hands and knees position and hanging the baby forward. That gives the baby more room to make that turn to the anterior. So getting out of bed, walking, leaning on the bed, leaning on furniture, all of that's going to help. I'm going to tell you a story about a mom that I was her doula for a posterior labor. And the baby was posterior almost all during the day. So the labor was very slow. Finally, the doctor came in and said, let's try an epidural, and I can perhaps kind of turn the baby to an anterior position. So the doctor came in and said, let's go ahead and give her the epidural first. So she got on her side. They were prepping her back when she took her hand and hit the nurse in the face. And the nurse said, just a minute, like, check her. And sure enough, that baby had rotated anterior, just like that, just from moving one more time on her side, like that. So that, then she just then basically delivered the baby, didn't have her epidural, had her natural birth, and, you know, it shows you how fast things can change in labor. So changing positions is very important. You're going to see this mom in this film do a lot of position changes, and this is Christina's birth. And I hope you get a lot of new ideas for ways you can use the hospital room and creative ways for getting out of the bed instead of just laboring in bed.